to make sure we all make sure, Dr. V.
Hi, Dr. Moore.
Sepsis update. Sepsis guidelines were updated in 2021 and wanted to make sure we go over the information. If you all have any questions, we're happy to answer. Please, unmute and ask or put questions in the chat because sepsis is very complicated and all of us are dealing with this, so we can learn together.
So I think sepsis is a great topic. I think sepsis keeps evolving and they keep kind of redefining what sepsis is. And even though they're redefining what sepsis is, the CMS criteria have remained the same and remain pretty consistent. So I think this is a good topic to go over and try to clarify some of these points. And please, we'd like everyone to get all their questions out and ask us any questions that you have.
So with sepsis, 1.7 million adults in the hospital get admitted annually. And 6% of the hospitalizations are due to sepsis. And of course, mortality is really high, 10 to 20%. It was even higher with COVID-19 when all that stuff started. So, and very, very, very expensive nationally, almost close to 40 billion.
Yeah, and the leading cause of death in hospitalized patients, I think, is really something that's very important and shows the importance of infectious disease doctors, right?
Yeah.
Yeah, which is, yeah.
And infectious disease pharmacists and our
right.
IPs and all of us.
Oh, I mean the whole team.
Yeah.
I mean infection, everybody.
Yeah. Us ID people are really important. So next slide.
Actually,
So,
sorry.
Can somebody, I think.
Here, I can just share what I got going on here.
Let's see, somebody's not muted.
Would you all be able to mute? Okay, thank you. So, we hear a lot about sepsis, but I also wanted to make sure we talked a little bit about sepsis in pregnancy. We all have pregnant females coming to our healthcare facilities. And as you know, in the United States, maternal mortality is steadily going up. Our rate is really high for maternal fetal mortality compared to a lot of the developing countries. So we're not doing very well. And one of the leading causes of maternal mortality, is sepsis. So it's really important to also recognize sepsis in pregnant females.
Right, and I've had a number of patients actually recently that come in and have very bad infections while they're pregnant or directly after they're pregnant. And so, it's something I've been seeing a lot of lately.
Yes.
It kind of comes and goes as far as what we see personally, but pregnancy is a very dangerous time, and I think it's good to highlight sepsis in pregnancy as something that's important to talk about for sure.
Yeah, and I think CMS is going to start focusing on this as well. So it's really important to also pay attention to pregnant females. And again, this graph from CDC really nicely shows maternal mortality per 100,000 live births have steadily gone up since 1987 to 2016. So more data is on its way, but the trend is very concerning.
Right, and it highlights that pregnancy is a very dangerous time.
Yeah, very dangerous. And also we need to do a better job. So here is from 2011 to 2016. And as you all see.
Yeah, infection is one of the leading causes. And so when we're looking at those mortality curves and thinking, what do they die from? And then here the causes of related death, and you can see that infection is high on the list, and something to keep in mind as evaluating issues in pregnancy, and again thinking of sepsis and septic shock is one of these causes.
A lot of times, we focus on bleeding after pregnancy, but number 2 cause is infection. A lot of time infections for pregnancy are like GU related. So, pyelonephritis, UTIs, bacteremia. If y'all can mute when you enter as well. So those things are really important to make sure that we keep an eye on sepsis during pregnancy.
And when it comes to sepsis, it's as far as what what are the causes of sepsis and how does it occur? Really, it's the body's overreaction, right? It's the immune system's overreaction to infection that's really the problem. And you can see here the unbalanced immune reaction, and you have mediators of inflammation causing all of these problems, vasodilation, free radical damage, capillary leak. And then on the left, you have tissue factor, procoagulant state, and but really, I think the thing to focus on is really the body's overreaction, and we'll talk more about this, I think, in the next few slides as well. And here's on the left, you see incidence of sepsis and mortality of sepsis, and the incidence of sepsis, it has it as going up, and then the mortality of sepsis, it has it as going down. And so over here we have incidence of sepsis increasing as time goes on, and the mortality of sepsis goes down. And why is this? And there are several kind of thoughts on this. And one of those thoughts is that that we're getting better at implementing the bundle and the overall, doing multiple things at once. So it's recognizing these patients that have sepsis or septic shock, and then taking action with multiple steps. And so, the QI projects that have really focused on this, and the hospital systems, and every hospital individually recognizing what they need to work on and how to get the whole bundle is really what's been shown to help, is kind of the thought about why this is the mortality is decreasing.
I think, CMS putting pressure through,
Right. Yeah.
CMS core measures, and as well as surviving sepsis guidelines and updates have really helped. So I think a lot of this, thankfully, we're doing a better job, but we need to do better.
And the evolution of sepsis care. So you can see on the left, they have source control, antibiotics, resuscitation, supportive care. And then as the mortality in those last graphs that we just saw has been decreasing, there have been a lot of things that have been tried here. And really, the established core treatment on the left and on the right is the same, except the ability to implement that is the thought that's been causing the improvement. So faster resuscitation, the correct antibiotics or more antibiotics, better supportive cares. And so all of these things that have been tried, they try them and they see if they work and not work. And sometimes the fad goes in and out, like steroids, no steroids. And it's hard to tell sometimes. And sometimes they'll say, oh, it may have helped some groups, but overall it didn't show, statistically significant advantage. But so it's been tough. But what we do know is that those bundles and doing everything together does have better outcomes.
Yeah, vitamin C, no vitamin C, Igris, no Igris. So
Right.
like a lot of things have come in and out of fashion, but known truth have stayed the same.
Right. And that's why, when we talk about sepsis and septic shock, these statements that everyone agrees on, it's hard to get everyone to agree. And when they show these panels, like for the Surviving Sepsis campaign, so many people from different areas, which is both good and bad. They break them down and they have certain panels for each topic, but getting everyone to agree on something is a challenge. And so even getting best practice statements can sometimes be hard to do. And then here we have infections, SIRS, and sepsis, and we have these overlapping. So here's SIRS over here, and there are good and bad things about SIRS. And one of the good things about SIRS is that you can use it in QI projects, and you can use it to try and identify patients within systems. And if you have an automatic thing that pops up and says, hey, this patient may be at risk for sepsis, septic shock, that being able to identify those patients is very important. And SIRS is one way to try and identify patients, but it's also important to know that there are other things that can cause patients to meet SIRS criteria. And so the good thing is it can be used to try and identify patients, and the bad thing is that sometimes it will include patients that are not meeting it because of an infection.
It just casts the net really wide.
Right. And it's better, I would say it's better than anything else that we have,
Exactly.
right? So they tried to go to QSOFA, but QSOFA it isn't something that can be used in practice for clinical care. And so that's why, CMS still uses SIRS criteria, And Q-SOFA, even though it came out in 2016, hasn't really been used by clinicians really in any meaningful way. But here's SIRS, and then with an infection, you have sepsis. And in sepsis, you have over here, this overlaps with infection, and have fungemia,
parasitemia, viremia, and other type of infections.
And here's bacteremia, and all these different types of infections that can cause sepsis.
You know, I recently had a malaria patient.
Oh, really?
So that will fall under pretty septic.
And then, you know, this is, you know, the SEP1, I think, goes back to 2001, and I think SEP2, or excuse me, that was in the 1991 or close to there. And then SEP2, I think, was from 2001. SEP3 is 2016. And so, you know, they keep redefining the criteria, and what they say is sepsis and septic shock.
So, you know, a little bit of like definition for SEP3. Define sepsis, life-threatening end or organ dysfunction due to dysregulated host response to infection.
And that's what we were touching on before. It's the patient's overreaction with their immune system. So they wanted to highlight the dysregulated host response to infection.
And then septic shock, a subset of sepsis patient with circulatory metabolic dysfunction associated with high risk of mortality and, you know, needing pressors and fluid resuscitation. But they say try to eliminate the word septic syndrome, septicemia, severe
sepsis, right? And if we have too many terms, it gets more and more confusing. And so I'm glad they're trying to, you know, pare it down and just get the most important: sepsis and septic shock. So I think that's great. You know, when people kind of throw these words around, it's you know, it can be tough.
It's too many, and it's hard to like decipher what's what. Yeah,
for sure. Yeah. And this is kind of the old terminology, but it's old terminology, but it's also terminology that is still used for CMS. And so they have, here's the top, you have the SIRS criteria.
Yeah, so SIRS criteria: temperature greater than 38 or less than 36, heart rate greater than 90, respiratory greater than 20, or PCO2 less than 32, and WBC greater than 12 or less than 4, or bands greater than 10.
So, and bands are an important thing to know.
Yes.
You know, there's a famous case in New York, and you know, the history kind of implementing all these things kind of goes back to, there was one young person that was admitted to the hospital and had high bands, and they said he had a viral syndrome, and he actually didn't. He actually had high bands that you know, high bands wouldn't be consistent with a viral syndrome, and he didn't get antibiotics. He didn't kind of go the right direction, and that kind of pushed for all of this criteria.
And you know, one thing to remember, like when you work with all the ID folks, we really like CBC with manual differential. So bands are usually immature neutrophils, and if it's auto differential or no differential, you're not going to get bands. So it's a really nice tool to get when there's somebody sepsis, you know, SIRS, get CBC with manual diff and pay attention to the bands. Higher the bands, more bacterial infection. Some elderly patients and some patients, your white count might just be 4, but if you look at the bands, they'll have like 30% bandemia.
Right, so they'll have a leukocytosis the next day.
Yeah, so it'll be just normal white cells, but then their bandemia is cranking up, lots of immature neutrophils. So it's really important to get that differential and look at it.
And then if you meet 2 or more of these criteria, this is 2 out of the 4 criteria, and then you have plus an infection, then it qualifies as sepsis. And then this was the old terminology: severe sepsis has end organ damage, and then septic shock, you know, you're having hypotension. And so this was the old terminology. And one of the reasons we like to go over the old terminology is because CMS still looks at this SIRS criteria and still looks at this old terminology. And we wanted to also mention the Q-SOFA because we've had questions on Q-SOFA. And Q-SOFA is something that was attempting to replace the SIRS criteria, although, you know, in clinical practice, the Q-SOFA doesn't really work as well.
So this is part of the updated 2021 Surviving Sepsis Guide campaign. In 2016, they recommended Q so far, but in
Yeah.
2021, expert panel say we recommend against using QSOFA compared with SIRS, Muse as a single screening tool for sepsis or septic shock. So they are advocating for other tools instead of using QSOFA at the current updated guidelines.
Yeah, so 2016, they said use QSOFA instead of SIRS, and then now 2021, they're going back to SIRS or something other than QSOFA. So, and this is why it can get so confusing when they introduce new things and then take them away. And then here's the CMS, and they go by SEP1, and this is, they have 3-hour goals and 6-hour goals. And within 3 hours, they recommend measuring lactate, drawing blood cultures, administering broad spectrum antibiotics. And the blood cultures ideally would be before you give antibiotics. And then for hypotension or a lactate that's 4 or greater, they recommend giving 30 milligrams per kilogram of fluids to try and resuscitate them within the first 3 hours. And then within 6 hours, they have repeat the lactate if the initial was greater than 2. Administer vasopressors if they're still hypotensive, so if they're not responsive to the fluids, then they recommend starting vasopressors. And then reassess volume status and tissue perfusion. And so this has been very tough to try and get all of these things completed because this has been an all or nothing measure.
Yeah, and it's been evolving, and a lot of healthcare systems try to implement different tools, alerts and like champions and like stewards for sepsis. But every system has their own way of doing this. But some of them have been automated, like making sure if you draw one lactate now, automatically the computer puts in an order for a second lactate after 3 hours. So people are coming with creative ways to take care of what needs to be done, but it's been difficult. It's been a journey.
Yes, it's hard for all the hospitals, and really, it's if you're looking at the patient having this time start in the most of the time it's in the emergency room, having this time start and then trying to do this over time as they transfer to the floor and the shifting responsibilities and everything. Like you said, it's been a challenge. Yeah. And here, this is the same thing that we just discussed. It's just looking at it, in a little bit more detail. And so that with a 3-hour and a 6-hour goals.
And then it's always important, of course, to get blood culture prior to antibiotic. But if they're crashing and you can't do it, give them antibiotic and then get blood culture. But ideal world versus sometimes what really happens, so something to keep in mind.
Right. And if they're, septic shock and they need antibiotics immediately, you want nothing to hold up the antibiotics because that time to correct antibiotics is correlated with a good outcome. So, if they're not doing well, it's best to order the antibiotics and have nothing hold it up. And yeah, sometimes we'll get a call and they'll say, oh, we haven't given antibiotics yet because we haven't been able to get blood cultures, or oftentimes it's meningitis where they say, oh, we couldn't get an LP, so we haven't given them.
Yeah.
Because they'll say, I've always been taught that we should get an LP before antibiotics. And it's one of these things where you want nothing to hold up the antibiotics if the patient's not doing well.
In my mind, like you said, LP, right? I'm giving broad spectrum and I could always tap later, like when it's, in 2 hours or 1 hour, but like holding antibiotics increases mortality and complication. So what will kill the patient most, and let's treat them first. So just making sure.
Yeah. And so it's with all these changing definitions and terminology, it's important to remember that sepsis definitions are messy and controversial, but clinicians should be worried about sepsis if there's a possible infection and any signs of organ dysfunction. And so, if you're seeing the patient, you say, they're having some signs of organ dysfunction and this might be an infection, it's important not to withhold antibiotics, give the antibiotics, and you can sort it out later. And if patients are not initially suspected of having infection, but if they develop unexplained new organ dysfunction, then, in your differential, you should have infection and sepsis, and it's something to consider. And it's not always very straightforward as far as the patient responding in predictable ways as having a fever and everything. And It's those patients that don't respond in a predictable manner that are really the tough, and also why it's hard to make guidelines when patients all, if they're too sick to kind of respond in a predictable way for a sepsis or septic shock. And Surviving Sepsis campaign, 93 total recommendations, so it's a lot of stuff.
There's a lot of little things. And then, I think main takeaway for us was like high risk patient, make sure you treat them with MRSA coverage, empiric fungal antibiotic, antifungal if they're high risk, what type of vasopressor medications to use, levodopa, it's a calcium channel, inotropic, makes your heart function better during sepsis, but they were not in favor of that.
No, they recommended not using that, and we'll discuss that too. Yeah, I think it's important to know what not to do as well, right?
Yeah, so we'll talk a little bit about that now.
Now, the acute phase, so when the patient comes in, now identifying sepsis as early as possible, and these are things that they wanted to stress, kind of the big picture. So identify sepsis as early as possible, broad spectrum antibiotics as soon as possible, identify sources of infection, identify the severity, and order lactate and volume and physiologic resuscitation as soon as possible, and tweak your system to these things happen fast. And that's really over time, when we're looking at things that made the difference, trying to identify it, trying to resuscitate and do all these things quickly is really the challenge.
And I hope like everybody's evaluating like in your own facilities door to initiation of antimicrobials and the time, and making sure you're within the right time to giving antimicrobials. So we'll talk a little bit about that. Do we have a question?
Oh, we had a question about ideal body weight for the 30 milligrams per kilogram bolus versus actual body weight in obese patients. Oh, that's a good question.
I need to follow up on that one. I believe it's ideal body weight, but let me double check that.
Yeah, I believe it's ideal also, but we'll have to look into that one and see.
So here is a really good organ failure and sepsis graph. So if you look at here, mortality. So as more and more organs get injured, like 1 or 0 organ, 1, 2, 3, more and more organs have end organ damage, the higher the mortality. So kidney starts having AKI, liver, you start having, shock liver, heart has like less cardiac output. Every single organ we're starting to affect, your mortality goes really high. So it's really important that's one of the reasons to recognize early.
Yes, and this is why they wanted to focus on organ dysfunction as one of the important things, in their terminology. And I think, and this is something to know as, especially as giving prognostic indicators to the family. And they say, how do you think, my loved one is doing? You kind of look at all the organ systems that are, as the organ systems shut down and you lose them, the likelihood of, having a good outcome decreases and decreases. Yeah.
So Surviving Sepsis campaign, sepsis and septic shock are medical emergencies, and we recommend that treatment and resuscitation begin immediately. So that's the best practice.
And this is about culture. So appropriate routine cultures be obtained before starting antibiotics in patients with suspected sepsis, septic shock. If doing so results in no substantial delay in starting the antibiotics. And this is what we were talking about, if possible, it's good to get
blood cultures, urine cultures, CSF, but if you can't, please don't hold up.
Right, don't hold back the antibiotics and the cultures. So it's, one from one arm, one from another arm, or if they have a port or a dialysis line, so it's one peripherally and one from the port. And it's essentially just do your best to get cultures before starting antibiotics. And this is something they looked at again with the Surviving Sepsis campaign, and they had a differentiation here between shock being present and shock being absent. And so sepsis is defined definite or probable. If shock is present, so this is the hypotension that we were discussing earlier, then administer antibiotics immediately, ideally within 1 hour. And this is, and sepsis is possible, you know, it's
Ideally, give it within 1 hour.
1 hour.
Yeah. So I think this is where a lot of healthcare facilities, you have opportunity to look at how fast are you giving your antimicrobials, right? And engaging your pharmacist, you know, in your floors, and have a way that, or Pyxis, that you can get antimicrobials within less than 1 hour. So I think that's door to septic shock, sepsis, antimicrobials within 1 hour is really, really important.
And so this is trying to say that if shock is present, then really whether you're sure they have, if this is due to an infection or not, give them the antibiotics. And so if there's shock, really you should be giving antibiotics and sorting it out later. And if shock is absent, you know, if you're pretty sure if it's definite or probable, you would give them antibiotics. But if you're not, then you may have a little bit of time to kind of sort things out. There are many things that mimic sepsis. And so you may have a little bit more time, and what they're trying to say is you have a little bit more leeway, you know, if the patient's doing okay, but
you're not sure if
you don't think it's an infection. But if you're thinking essentially if infection crosses your mind, you should probably be giving antibiotics and sorting out later.
Yeah. And this is not the time where we worry about like antimicrobial stewardship or antimicrobial stewardship. It's always important, but this is, you know, when there's shock therapy, broad spectrum, and then.
Right, because it's so important to these patients, and there's a lot of, you know, it's not very clear. So because it's not clear at this time, it's better to err on the side of giving the antibiotics to these patients.
Yeah.
And this is the same, essentially the same table. It explains just exactly what we were just talking about. Yeah.
And this is from Society of Critical Care Medicine. They have nice slides on surviving sepsis campaign. If you all need it, it breaks it down really well.
And when it comes to MRSA and fungal coverage, you know, we cut this right from the surviving sepsis, but it's essentially if they're at risk for MRSA, then give them MRSA coverage. And if you're thinking about fungal infection, that might be a possibility. It's better to give them the antifungal and then again try to sort it out later.
Yeah. And then, so this is a little bit different from the 2016 surviving sepsis guidelines. So now MRSA coverage is new. If you suspect, you know, before they were advocating for gram negative, and then, you know, give gram negative first, then, you know, CMS was saying gram positive later. Now they don't care, just give an IV antibiotic, whatever it is. But MRSA coverage is important too. So if a person is high risk, make sure we are covering for them.
And then we wanted to show some examples of antibiotics. So these are examples of sepsis antibiotic regimens for different concerns. So if you have abdominal or CNS or you know lung, then what antibiotics would be recommended for those concerns? And really, this is one way of looking at it. Ideally, you'd be thinking, what bacteria do I want to cover, and then what antibiotics should I choose? But in these situations, it's good to kind of have something like this where you can help sort it out very quickly and have a protocol in place.
Yeah, and I think that's the most important thing, right? Each facility having like your own protocol for antimicrobial, because you know what kind of infection majority of the time it shows up in. So giving guidance to your frontline providers will be really helpful. If abdominal, you got to cover belly flora. So, piptazolzolin would do a great job, or you could do cefepime flagyl. So having choices and then, being able to decide what sepsis, what kind, and being able to pick is really helpful. Again, what you were saying about having bundles. So we know bundles are helpful, and also for antimicrobials, having this type of order set is really helpful.
And this is time from hypotension to appropriate antibiotics. So hypotension, this is going to be like septic shock patients, or giving the right antibiotics and time to appropriate antibiotics is correlated very well with good outcomes.
So it's crazy if you look at here, as the hours go by, the mortality rate starts raising up here. So by, if you didn't give antibiotic and hypotension has been going over for 36 hours, almost 100% mortality. So, it's really important. Sooner we give antimicrobial, less mortality and recognition.
Right. And so, if you're not sure, but they're hypotensive, like those slides were saying, if you're not sure if it's pseudoinfection, but if you have a hypotension patient, then you'd want to give them antibiotics, and then you can, reevaluate and see how things are going a little bit later and see if there's a cause other than infection. But because antibiotics are so important early on, it's important to give them and then reevaluate.
This graph is from 2006, but it applies really well even now.
Yeah.
Very nicely illustrates the point.
And we wanted to have a slide, showing the antimicrobial stewardship, this kind of balance of how do you balance the goals of antimicrobial stewardship and not giving overuse of antibiotics with early broad spectrum treatment for sepsis and septic shock. And really the answer is that, and this is something that kind of divides people in when it comes to sepsis and septic shock guidelines and recommendations and protocols and everything. But really, like we've been saying, and I think we've just been kind of repeating it because it's so important, that antimicrobial stewardship fits in by giving broad spectrum antibiotics up front, and then the quick de-escalation if it's not needed.
Yes.
Is how antimicrobial stewardship fits in.
So when your culture comes back, patient is stable, you have more information, then you could start peeling things off and, narrowing and, treating for whatever it is, like pneumonia for 7 days, pyelo 7 to 10 days, you come up with plans. But up front, I think it's really important, septic shock, sepsis, thinking broadly.
Right, and these are the patients that we review with antimicrobial stewardship. We'll get a list of patients, and there'll be patients to kind of look at and see if they need antibiotics. And some of those patients, when they first came in, they were considering that they had an infection, and so they started antibiotics, and then they may have kept them on it for 5 to 7 days or something. And they'll say, oh, it turned out to be something else, but we're keeping the antibiotics just to be sure or something. And that's the role of antimicrobial stewardship, would be appropriate de-escalation.
Yeah. So part of the guidelines, and for part of the surviving sepsis guideline, we recommend that empiric antimicrobial therapy be narrowed once pathogen is identified and sensitivity established, and adequate clinical improvement is noted. So that's what we were just talking about. We suggest that antimicrobial treatment duration 7 to 10 days, adequate for most serious infections.
And I think in the past, people would usually give at least 2 weeks, but 7 to 10 days, if they're doing well at 7 days or so, and you've gotten it under control, then stopping antibiotics would be reasonable.
We recommend daily assessment of de-escalation of antimicrobial therapy. So it's important when you have our septic shock patients, reviewing the patient as a team daily and kind of de-escalating and targeting the right pathogen. And we suggest a measurement of procalcitonin, and we'll talk a little bit about how procalcitonin will help with sepsis and septic shock in a little bit at the end.
Yes, I don't know that I've ever had patients have a poor outcome because of the duration of therapy. I think it's so linked with the correct antibiotics up front and not duration. That, even when we decrease the number of days of treatment, I don't think I've ever had patients return and
I think you're right. Like, I think we used to be like 2 to 3 weeks, now 2 weeks, now 7 to 10 days.
And let's see, lactate. So evidence clear that lactate levels are predictive of death. And so a really high lactate in septic shock patients is predictive of death. So that's you can be used as a prognostic indicator. Clearance of lactate is associated with improved survival. That's true. That's partly coming under a bit of question. That bringing lactate down quickly, some of the studies aren't sure if that's really associated with improved survival, although but that's why we're going to talk about procalcitonin, because procalcitonin decreasing has definitely been shown to have better outcomes.
But for CMS measures, you have to monitor your Yeah, so, initial and then 3 hours later, making sure if the initial lactase were elevated, you have to recheck.
So it's important to recheck even with these
Yes.
controversies, right?
Yeah, we're talking about
Yeah.
things outside, but for CMS, we got to follow what exactly they want us to
Yes,
do.
Infectious Disease Society of America has come out with a position paper, which is very interesting to read, and I recommend looking at it just kind of for interest. Yeah.
So initial resuscitation, we recommend that the resuscitation of sepsis-induced hypoperfusion, 30 ml per kg, fluid to be given in the first 3 hours. We recommend the following initial fluid resuscitate additional fluids be guided by frequency of assessment and hemodynamics, and trying to keep your MAP above 65.
Yes, these are all good recommendations.
Weak recommendation. So about corticosteroids. For adults with septic shock and ongoing requiring of vasopressor therapy, we suggest IV corticosteroids. So,
and this was upgraded from the past where they would say, and this was the change. In the past, they said against using corticosteroids and if adequate fluid resuscitation but
if not achievable, then you could give hydrocortisone, but it's a very weak. So try other pressors and fluid first.
Yeah, this was the past, but this is the current recommendation.
So we have a chat box. What fluid do you use resuscitation? Normal saline versus ringolactate versus normal osmo. Normal saline is what?
Normal saline, yeah.
Okay.
And then they commented on vasopressors, and it said, use norepi as first-line vasopressor. Target a MAP of 65, and then, let's see, if MAP is inadequate despite low to moderate norepi, consider adding vasopressin. And let's see, and actually the next slide actually goes into this.
So they want you to start with norepi, and then they want you to go to vasopressor. So their newer way so recommend norepi as your first choice of vasopressors.
And then use norepi, and then you can either add dobutamine to norepi or going with epinephrine alone. So this was their recommendation. And
then if you look below, for adult septic shock, cardiac dysfunction with persistent hyperphagia despite adequate volume arterial blood pressure suggest against using the levodomin. Yeah, I'm killing the name, but yeah, they're recommending against the use, the newer guidelines. And then we kind of want to touch base about, there's been some new studies on procalcitonin. So with procalcitonin, normal level for immunocompetent patient, it's like 0.35 or above, you start worrying a little bit, right? But so if you say no infection in here, very low, all over 0.01 to, a little bit more than close to 1. SIRS, no infection, still around 1. Sepsis, then the actual value starts going up to like 10. But what they notice also is severity of sepsis, the higher the procal. So in severe sepsis, we don't use that term anymore, and in septic shock, your procalcitonin level is very high. So the level of procalcitonin correlates with severity of illness. So usually sometimes in septic shock, my patients are procal of 70, sometimes it's unmeasurable, more than 170, right? So it's a really nice tool. I always say it's not diagnostic. It's a tool that helps you see how severe the sepsis and how they're doing. So it's prognostic.
Right, not diagnostic, meaning if they come in and it's low, you wouldn't say, oh, this is not sepsis or not septic shock. But you really wouldn't do that with anything. If they come in and they look like they're septic shock, you wouldn't say, oh, they don't have a leukocytosis, therefore it's not. So you wouldn't use just one lab value to make all of your decisions. And so sometimes people will say, oh, how would procal help? Because they expect to make all the decisions based off of the procal, and you have to kind of look at it, globally with all of the information you have. And so it's just one more thing to look at and help you decide. But really, it shouldn't be used to start antibiotics. It should be used to stop antibiotics.
And, whenever I'm teaching, I always say, patient in the middle, and you're putting the story together, like the white count, the blood pressure, the bandemia, and the procal is another point that makes the story for what's happening with the patient. So I think that's how it's important to use.
And so if they come in, it's not high, it may be high the next day. It may peak the next day and start coming down. So even if they're on appropriate antibiotics, it may still peak the next day and then start coming down, as this graph.
Yeah, so this graph actually looked at septic shock patients, and they looked at when their procal is elevated and when you have them on right antibiotic and it starts coming down, does procal correlate with mortality? So what they found out was in septic patients, when the procal came down more than 80% of the baseline in the first 4 days. So let's say the first day was 170, and now in fourth day, it's down to like, I don't know, 20, 30. So if it came down more than 80% from the baseline, they had better survival. So if you look at the graph, rapid decline in procal, which just means you're getting them on the right therapy, patient is doing better. They had better survival compared to non-rapid decline, had a higher mortality, twofold higher. So again, procalcitonin now can, not in pneumonia, but in sepsis, can help with mortality by trying to bring the procal level down. Is another way of telling you they might have higher mortality. Let's treat this patient. One of the other things I do too, let's say I have like E. coli bacteremia, right? And my patient has like procal 100, and I'm treating them with like Zosyn, right? And then tomorrow I come in and their procal went up to 170. For me, that is oh my goodness, do they have ESBL, right? Do they have some resistance? So I immediately changed them to ertapenem. And this happens a lot. And then you end up finding out there was a resistant bug. So that's another tool to use procal too. You look at the trend, and if it's going up, you probably need to change your therapy because you're not targeting what you need to be targeting.
Right. If the procal is increasing, I'll be escalating antibiotics.
Yes.
Exactly what you just said. Yeah. An increasing procalcitonin is very bad.
Yes.
And so the antibiotics need to be adjusted in those cases for sure. Yeah.
So that is our update. Right, 2 minutes left, right on time, but we would love to open it up for questions because this is such a difficult, complicated topic, and love to answer. What would you say to providers that practice conservative fluid on sepsis in heart failure patients? I think
this part's evolving. So now there are some studies that show that getting the fluids, so I should start by saying this is controversial. It's evolving, but it's also controversial. And when you look at reasons for fallout, reasons for patients not making, all of the criteria, the big ones are lactate, and the other one is the fluids, right? And, when it comes to fluids, these are some of the parts that are controversial because, patients that, they're heart failure patients or dialysis patients that are going to get overloaded. Those are the patients that, part of the reason IDSA has some pushback on some of these regulations is that they would say you have to do this for all of the patients, and it doesn't allow a person to actually make clinical decisions like this. And so, it's tough because, in the past, they didn't allow people to, it was an all or nothing CMS requirement. They had to do every single thing, no matter what. And then they're starting to open it up where you can say, and you can actually give a reason for it and say, I didn't give this much of the fluids because they have heart failure and I'm worried about it. And so they're starting, I believe, to allow.
Yeah, you could put it not sepsis, right? But there's another way to do this too. So let's say this patient is in the ER and you're worried about shock, and if you don't want to give that much fluid, so Brent, do you guys do the 126 ml per hour while you were doing the workup as well? Because instead of giving the giant bolus, you could also do the 126 ml per hour. That's an option. But another option is, I think you can also, if they're crashing, you could give fluids and you could always diurese it later.
Right, support the blood pressure.
Yeah.
over everything.
So I think it's clinical decision making, but I have had, when reviewing cases, fallout because it was sepsis and they didn't give enough fluids. So it's okay to be aggressive up front, but making sure that once you get data back, you back off and give diuresis if you need it.
Right, and the IDSA, when I was saying that they had some pushback, they actually left the fluid amount and everything to other societies. They commented on the antibiotics and the lactate, but when it came to the fluid resuscitation, they didn't comment on that, and they left it as well as the vasopressors and things like that. But I would say that that's kind of a controversial area that it's a difficult situation, because it's hard to say that giving fluids or one path is right for everybody. But really, with the sepsis recommendations, they're trying to make sure that for patients with an infection that supporting the blood pressure is so important. And so, if it's possible to give the fluids, I would really try my best to give the fluids. But again, it's tough because it's tough to give one recommendation for every single patient.
Yeah, but you also have to think about fallout, right? If it's sepsis, so
Yeah.
Sometimes you have to be
Right.
aggressive up front and then back off.
Yeah.
Unless the provider can clearly document this is not sepsis and this is just heart failure, then you won't fall into the CMS core measure monitoring.
Yeah, and so these are controversial topics, and there's certainly that there are good and bad things with making everyone do the same thing for every single patient, for sure.
Other questions you all had? I'm going to follow up on the ideal versus adjusted body weight, and when we send out a slide, I'll make sure to answer that question. Have the bundle been updated with the new guidelines?
The bundles with the new guide? No. So the CMS hasn't updated with the surviving sepsis.
Yeah. They're not together with the surviving sepsis.
Yeah. So they still go off of CMS still goes off of SEP 1 criteria with the SIRS and everything. And
yeah.
And that's difficult. Going back on many years of QI projects is also the concern, because if CMS makes their changes, then every few years things change so much, and CMS doesn't respond that quickly.
Yeah, they have unfortunately not changed, but I am hearing they're going to start focusing on pregnancy. So that's one of the reasons, I put a little bit of information on there. I have to read more about it. But it's important to know that pregnancy they might give us some guidelines upcoming on that as well, on how to make sure we don't miss.
All right, thank you, everybody. And if
you have any questions, please email us. We sent out a flyer with upcoming webinars until December. So thank you for joining us.